Good evening, everyone. Thank you for joining us. My name is Danish. I'm a pulmonary and critical care as well as an interventional pulmonary attending at Fox Chase and Philadelphia, Pennsylvania. It is my pleasure today to introduce Dr. Abu Za'nouneh. Dr. Abu Za'nouneh is a PGY3 internal medicine resident at the University of Hawaii. He completed his medical school training in the University of Jordan Science and Technology. Dr. Za'nouneh, thank you for joining us. Please proceed with your case.
Thank you, Dr. Danish, for having me. It's a pleasure to be here. So today we'll talk about utilizing Venovenous-ECMO assisted tracheal stenting for malignant central airway obstruction. This is a case series that was done. These two cases were done at Straub Benioff Medical Center. So starting with case one, we have a 70-year-old male patient with a 50-pack year history of smoking, hypertension, type 2 diabetes. The patient presented to the ED with shortness of breath and hoarseness. His vitals were pretty stable with a normal range, except for oxygen was at 90%, requiring 3 liters of oxygen in nasal cannula. Physical exam-wise, they were positive for hoarseness, expiratory wheeze, and speaking in short, interrupted sentences. Labs were pretty unremarkable, and we don't have any previous imaging or pulmonary workup. So we got a CT scan of the chest, and it showed the large necrotic right supraclavicular lymph node and a paratracheal lymph node measuring 5 by 8 by 9 centimeters, causing a significant tracheal deviation and severe tracheal airway narrowing and extending, actually invading all the way to the inferior pole of the right thyroid. We also did a CT abdomen, which showed multiple hepatic metastases. And later on, after the bronchoscopic procedure, we had an ultrasound guided biopsy of the supraclavicular lymph node, which showed us stage 4 small cell lung cancer. So this is the CT chest imaging. I couldn't get a video, but by the looks of it, we can see a right paratracheal mass causing a trivial deviation and significant narrowing of the trachea on both the axial and sagittal views. Continuing with the case, the team had a discussion with the patient, and it was decided to do a palliative tracheal stent placement. Multidisciplinary discussion was done, and including CT surgery, anesthesia, IP, and RTs on our ends. It was decided to do a preemptive awake bifemoral VV-ECMO, given the high risk of airway compromise if the patient were to be intubated prior. The reason why we elected for a bifemoral access is that the patient had the tumor extended and compressing on the SVC, so it was kind of tricky to do a right IG access. Flexible bronchoscopy showed a severe proximal tracheal intrinsic compression, and we did a balloon angioplasty twice, followed by fluoroscopic guided deployment of a 16 by 40 balloon expanded metallic stent. Shortly after the procedure, the VV-ECMO was decannulated, and the patient was breathing in room air. We sent them back to the ICU for close monitoring for 24 hours before being downgraded. Unfortunately, the hospitalization course was complicated by recurrent right-sided malignant pleural effusion requiring multiple thoracentesis and ultimately an Astra drain placement. During that course, the patient finished 5 sessions of palliative radiotherapy, but unfortunately, their quality of life continued to deteriorate. The patient elected to transition to hospice, home hospice. Later on, the patient passed away. So this is the fluoroscopic image of the metallic stent that was placed, and the chest X-ray showing the metallic stent in place. Going to case 2, we have a 59-year-old female, relatively young female, with a stage 4 endometrial adenocarcinoma with metastatic right paratracheal lymphadenopathy. The patient presented to the ED with dyspnea and stridor. She does have a previous history of getting treated, of having a surgical history, of delta abdominal hysterectomy or laparoscopic hysterectomy and bilateral salpingio-oophorectomy with sentinel lymph node dissection and chemo and radiotherapy. That was done 5 weeks in Boston. After that, 5 weeks ago in Boston, the patient had the tracheal stent placed and the tumor debulking. When the patient presented to the ED, her vitals were pretty normal. She was satting 97% on room air. Physical exam was only notable for biphasic stridor and also interrupted speech. Her labs were pretty unremarkable. We had a CT chest and neck, which showed a 2.8 by 2.6, 3.7 centimeter right paratracheal metastatic mass invading the distal trachea below to an existing tracheal stent, causing a leftward tracheal deviation and a 90% narrowing of the airway. So we have the CT chest on the left and the CT neck on the right. We can see the metallic stent placed in there and the tracheal mass just invading below that and causing a 90% occlusion of the airway. Similarly, in the CT neck, we can see the same findings there. So a multidisciplinary discussion was done, and patient it was decided to do a preemptive femoral jugular VV-ECMO, since as the intubation was high risk for cardiac respiratory arrest for this patient. But she was intubated afterwards, after the VV-ECMO was in place. Flexible bronchoscopy showed endobronchial mass distal to the stent, and this is the image of the tumor extending below the stent. We can see the stent edges right here, and then this is the tumor extending, occluding almost 9% of the airway. We did a tumor debulking with APC and cryotherapy, and we achieved almost 70% patency of the airway with that. Some institutions do stent-on-stent treatment or technique, but we haven't utilized that because some of the edges of the tumor was invading the side of the stent, and there's a risk of tracheal perforation with that. And we achieved 70% patency, and the patient was breathing on room air, so we left it at that. As soon as after the procedure, the VV-ECMO was decannulated, and the patient remained intubated overnight just for airway monitoring, because she had this recurrence only within 5 weeks. We did a surveillance bronchoscopy the following day, which showed a patent airway without evidence of bleeding or restenosis. The pathology was consistent with a metastatic endometrial carcinoma, and the patient was started on carboplatin and paclitaxel, and she was discharged, and she traveled back to Boston to follow up with her oncologist. So I'm going to give a quick run through on MCAO, malignant central airway obstruction. We're going to go through the definition, epidemiology, different types, treatment options, and what is the current recommendation when to use VV-ECMO, and what's the evidence, current evidence in using VV-ECMO. So by definition, currently on the chest guidelines, it's defined as a 50% or greater occlusion, whether it's in the trachea, mainstem bronchi, or bronchus intermedius or lobar bronchi, caused by either an advanced thoracic or extrathoracic malignancy. It commonly manifests as either as a dyspnea, stridor, wheezing, hemoptysis, respiratory failure, and just an overall general decreased quality of life. We don't have an estimate of the incidence and prevalence so far, but it's estimated that 20 to 30% of lung cancer patients experience central airway occlusion related complications, and up to 40% of these patients actually die from local regional disease. Types include intrinsic. So if we have the tumor growing from the inner wall of the trachea or the bronchi. Extrinsic, if we have a, like in our case, we had case 1, we had a paratracheal lymph node that is compressing and narrowing the trachea. And mixed, like the second case, where we had both intrinsic and extrinsic mass causing stenosis and narrow the airway. So this is a quick algorithm based on the 2025 chest guidelines. So when we have a malignant central airway obstruction, we have to think, is the patient a surgical candidate or they're not a surgical candidate? If they are a surgical candidate, we just go with surgical resection, and with oncology, we start the patient on systemic chemoimmunotherapies or radiotherapy if indicated. If they are not a surgical candidate, I have to think based on the type. is this tumor, could this tumor be debrided or ablated if it's an intrinsic tumor or endobronchial tumor? I have to think about using different modalities of like bronchoscopic therapies. If it's an extrinsic tumor or compression, I have to think about stent placement. And the guidelines recommend or suggest to use rigid bronchoscopy under general anesthesia with either a jet ventilation or spontaneous or controlled ventilation for therapeutic bronchoscopy. So these are quick examples of the types of the malignant central airway obstruction. We have an endoluminal obstruction, secondary to carcinoid tumor in the right upper lobe. In figure B, we have an extraluminal obstruction compressing on the left lower lobe, causing compression. And in figure C, we have a mixed obstruction from a right paratracheal mass with endotracheal extension. These are the different types of treatments. In the first row, we have an endoluminal LMS left main stem tumor, and the tumor was removed by an electrocartridge snare and APC. In the second row, we have an extrinsic compression of the LMS, and we have the patency was achieved with the balloon tracheoplasty and placing a metallic stent. Looks like a self-expandable metallic stent. And in the third row, we have a mixed obstruction in the RMS and the bronchus intermedius, for which an APC was done and a balloon dilation and stent was placed. So what is the current recommendations? So per chest and World Association of Bronchology and Interventional Pulmonology guidelines, they recommend that stent to be placed for patients with symptomatic malignant or non-malignant central airway obstruction, mostly for symptom control and to improve the quality of life. The chest guidelines elaborate more in depth on that they recommend rigid bronchoscopy over flexible bronchoscopy in symptomatic central airway obstruction, and to be performed under general anesthesia, whether jet ventilation or controlled or spontaneous assisted ventilation. The reason for the recommendation of the rigid bronchoscopy is that it has benefit in stabilizing the airways, serving as a conduit for ventilation and enabling coring through large tumors. And we know it has an excellent suction, effective tamponade if bleeding happens, and it allows insertion of flexible bronchoscope or rigid forceps and placement of silicone stents. But the acquire registry found no significant difference in airway recanalization success or complication rates between both the flexible versus the rigid bronchoscopy. Success rates were pretty similar success rate of around 93% versus 93.5% respectively. Likewise, in terms of the mode of ventilation, whether it's a jet ventilation versus controlled spontaneous ventilation, 93% to 96% respectively. So the choice for the bronchoscopic approach, whether it's a rigid or a flexible, and the ventilation strategy should be individualized based on a multidisciplinary discussion and case-by-case scenario. And depending also on operator experience, institute availability, and the location and the severity of the airway obstruction, and the type of the stent to be that is being deployed. Unfortunately, so far, we don't have any, neither of the guidelines offer any specific recommendations for VV-ECMO using during airway intervention. So that takes us to an important question. When do we consider ECMO for high-risk patients? Technically, we don't know. We don't have any guidelines. We don't have any RCTs or like prospective clinical studies. However, in critical tracheal obstruction, we could consider using VV-ECMO when the mechanical or jet ventilation may not ensure an adequate gas exchange. If the patient has a really critical airway narrowing up to like 9%, and we don't have adequate oxygenation with that, or we anticipate that we won't have an adequate oxygenation with the ventilation, we might elect to use VV-ECMO. If there's even a minor risk of bleeding or clotting with critical airway obstruction, if I'm manipulating, debulking, doing an APC, trying to remove a tumor, if there's a risk of clotting or bleeding, I would elect for a VV-ECMO. if the patient has a high risk of respiratory arrest during induction of the anesthesia. Also, if I anticipate I'm going to have difficulty with using the rigid bronchoscope, especially with advancement to the distal airway. At times, if I have a bilateral mainstem bronchial obstruction, I could just elect to use the VV-ECMO. Sometimes it's just institutional experience or preference. Touching on if in other situations other than critical tracheal obstruction, we've seen it to be used in whole lung lavage and PAP. So when we want to utilize the ECMO, we have to weigh in the risk. We have to think about the complications. The complications, the literature reported in the literature vary widely, and these include bleeding, hemolysis, air leakage, strokes, infection, and thrombosis. We have to think also about that the ECMO is a resource intensive procedure, as it requires specialized staff, certain ICU capacity and equipment, and we have to think about the cost. And we have to think about the endpoint for those patients. So the evidence, I left a couple of research papers. Most importantly, actually, was the systematic review done by Wu et al., which discussed 107 patients under ECMO. Most of them, 62% almost, was tumor-related airway obstruction, and 57% of the treatment was airway stent placement. In that systematic review, it showed that the median ECMO duration was 40 hours, with a 92% of patient survival to discharge. So I'm just going to quickly go through the study. I quickly did a deep dive in the supplementary data, and the number of patients who had a tracheal stent placed were 40 out of the 107 patients. Unfortunately, the study mentions ECMO in general, whether it's a VA ECMO or a VV-ECMO. So, but in the tracheal stent patients, only VV-ECMO was utilized. It also does not fully mention or separate the complications in which type of ECMO and which type of patients. But based on the supplementary data, the complications out of these 40 cases, there was only 3 cases, and one of them had an airway bleed, one of them had a femofemoral AV fistula, and one of them had a femoral vein hematoma. Going back to the second study, which is by Park et al. Done in 2017, it was a retrospective study done on 7 patients with malignant airway obstruction. All patients had a fluoroscopic stent placement under VV-ECMO, and it showed 100% procedural success with no related complications. Another retrospective study was done by Hung et al., which is on 19 patients with severe airway obstruction. 19 of them were on VV-ECMO, and 7 of the cases had tracheal stents. The median ECMO time was 21 hours, and out of the 19 cases on VV-ECMO, 18 were successfully weaned off the ECMO. One of the patients died due to complications related to the procedure. It was bleeding. And the rest of the studies were a couple of case series and case reports mentioning about using VV-ECMO. I won't go through these studies since we don't have a lot of time, but I briefly touched on them. So what is the take-home points from this case series? It's that we don't have any validated criteria yet to identify like high-risk patients that prohibits like airway interventions. We need a multidisciplinary evaluation, including interventional pulmonology, critical care anesthesia, and ECMO surgery to weigh the risks and benefits in a timely manner. From the studies we saw, there is a rise in using VV-ECMO as a short-term bridge for high-risk bronchoscopic interventions, particularly in patients that these procedures won't be done given the high risk of airway compromise. But the VV-ECMO helped us utilize that. It could also be used as a compassionate bridge to palliative relief of airway obstruction, and perform a biopsy to inform the prognosis and the therapeutic strategies to the patients. Um, Awake VV-ECMO is something that is increasingly being adopted in the last couple of years, and the thought process behind it is to preserve spontaneous ventilation during cannulation and anesthesia induction. I think one of the most important parts is to set expectations early with patients and families, as we don't want to be in a bridge to nowhere situation. So I think it's important to elaborate to patients that the VV-ECMO is just as a short bridge to do the procedure rather than as a bridge towards an endpoint, which might not be existent, especially in patients with end-stage cancer or like stage 4 metastatic cancers with poor prognosis. If VV-ECMO, since ECMO is a resource-intensive procedure, um, consider placing a vascular access without completing cannulation. Consider placing the sheaths without cannulation, quote unquote standby ECMO. Just in case things go south during the procedure, you could just expedite the initiation of ECMO while avoiding any unnecessary exposure. Um, we have to take into consideration that there might be a publication bias. Unsuccessful cases and complications may be unreported, especially that all the case reports mention only successful utilization of VV-ECMO, but I haven't seen any cases about failed VV-ECMO. We need clinical trials, we need prospective studies to help us better standardize who is the high risk patient and who's the ideal patient and when is the ideal timing to use the ECMO. I would say also hope for the best, but also prepare for the worst. So going back to our patients, so the rationale for VV-ECMO for our patient is because they were both at high risk of respiratory arrest or like complete airway occlusion during induction of anesthesia. In patient one, both patients, we did a primitive VV-ECMO, but in the first patient, we did an awake ECMO. We utilized the bifemoral cannulation. As I've said before, the right IJ was relatively precluded given the superior vena cava tumor compression. For the second patient, we cannulated them prior to intubation, given also the high risk of airway arrest. However, both patients were immediately decannulated after the procedure, and they were monitored overnight in the ICU before being downgraded. Patient 2 remained intubated and scoped the following day just to look for restenosis or bleeding. Ideally, you can use the rigid bronchoscopy with or without jet ventilation, but given the limited institutional experience, we don't really have rigid bronchoscopy in Hawaii. And ECMO was more favored given the institutional expertise in ECMO, and all of our intensivists are ECMO trained. Also worthwhile to mention is that both cases were heparin-free, given the short-term use of the ECMO and the tumor the bleeding risk with tumor debugging. And I guess that's pretty much it. Thank you.
Thank you, Dr. Za'nouneh. Both of those cases are excellent. I really found them both to be fascinating. I think the most important point you made was about institutional experience. So there may be centers that have better experience or more experience with rigid bronchoscopy, and they may be more comfortable in these cases to proceed with possible rigid bronchoscopy while the patient is spontaneously ventilating. That's one strategy, as you touched on. Another institution like yourself may be more experience with VV-ECMO. So I really think just employing the expertise that is present at your institution to help the patients and get them through the acute critical event situation, as you pointed out, is the best treatment paradigm for the patient. I did have a couple of questions in the chart. One of the questions was, did you guys think about standby ECMO instead of going ahead with ECMO in of itself for either of these cases?
So that's a good question. We proceeded with ECMO because the patients were at a really high risk of respiratory arrest, especially that both cases, the percentage of the narrowing was around 90%. So we did not want to risk even the slightest risk of having a respiratory arrest, and then everybody's gonna panic, and then we're gonna start, oh, let's take the patient to ECMO immediately and all that. So just as a anticipatory thing, we were like, okay, let's play it safe. Let's just use the ECMO. We have the modality, we have the tools, we have the expertise. So we elected to use immediately just to use the ECMO. But I totally agree. If it's more in the gray zone, at least we would get the sheaths in, I think, without cannulation, and just put it on standby and alert the team the ECMO team on standby in case if anything happens. Immediately we could cannulate and start the VV ECMO on the patients.
Yeah, I think you make a good point. It's really the critical nature of the airway that really makes the decision for you. And oftentimes in the past, when I've seen standby ECMO, the ECMO team is actually in the OR or in the procedure room, generally in the OR with you, making sure that in case the patient requires to be cannulated and initiated on ECMO, that they can do that in short order. Another question that I saw was about the second case you had with the patient with the pre-existing stent. Were there any thoughts about pulling the old stent and placing a newer, longer stent in the airway, as you already had ECMO on site and you could, I know you debulked and you got patency of the airway, but you could place a stent to maintain that patency?
Mm. That's a good question. I think it's also institutional dependence whether you feel comfortable with pulling an old stent. I know a lot of not a lot of like IP physicians favor to pull an old stent unless um, it could, I would say, significantly change the management, because it also comes with risk. Like especially in our case, some parts of the tumor was embedding into the stent. So it's going to be hard to pull that stent without causing any further complications on top of the criticalness of the situation that you're in. I guess the other thing also is the patient is originally from Boston, and they're following with their primary team in Boston, and they were in Hawaii just for a vacation. So it's really hard to step your foot into somebody's else like like whatever they worked on. It's kind of hard. So just as much as to make the patient stable, feel better, breathe better, and then just to safely travel back and fly back to Boston to continue their care.
I was surprised when I saw that part of your presentation that the patient actually traveled to Hawaii with the malignant central airway obstruction. I guess no, you can't stop anyone from coming to Hawaii. So I guess they could book. Well, thank you so much for your time. I know we are hitting against the 7 o'clock time, so I wanted to thank everyone for their attention and for being here for this very excellent talk. Thank you once again, Dr. Za'nouneh.
Thank you. Appreciate it. Thank you.
Take care.